if you do put like an ultrasound right here, what you will see? Skin, superficial layer epiderma, superficial fascia with some fat in the middle, deep layer epiderma, 1, 2, 3 layer, perimysium, vastus lateralis. So I'm asking the patient to push the knee against the table, isometric contraction. And with an isometric contraction, transducer right here, they push down like that. Look, with the isometric, can you see the 3 layer, how they glide? But they don't glide all in one direction. They glide like that, isn't it? And this is a 2D. Is a 3D will be like that. Okay, so with the isometric contraction, you already have this kind of movement. Think about full range of motion, how the layer has to glide. Sciatic type pain, you do ultrasound, you do the same, and you will see this. Okay? And it means irritation of all the receptor in specific line of force. So you can have a sciatic type pain, sciatic type pain, sciatic type pain. That have nothing to do with the radiculopathy, but just an irritation of the free nerve endings in specific line of force, fascial lateral fascia. Severe, dramatic situation, the patient is crying for the pain, you treat it, it's brand new. Okay. Because it's just related to this. Then, of course, the glide is important. So the black substance right here, this loose glandular tissue is very fundamental. Because if it becomes viscous, you have a problem. And that is related to adipose cell, glycosaminoglycans, and hyaluronan. Hyaluronan is really the chief component of the loose glandular tissue. It's like a lubricant that you find out in the endomysium, in the perimysium, but also in between epimysium and the fascia. All this black right here is all hyaluronan and adipose cell. In the past, people have evaluated who is producing the hyaluronan in the body. And they find out particular cell that produce this substance. And they studied the retinaculum of the ankle because Vesalius in Padua in the 14th century, he wrote the first atlas of anatomy. He said, look, the retinaculum is a pulley for the tendon. So if it's a pulley and the tendon go below the retinacula, there has to be a lubricant, otherwise you have friction. So they find out that below the retinacula you have a lot of cells that produce hyaluronan. But we find out that cell all over the body because you need the lubricant all over the body. And we call that cell fasciacytes. Cell of fascia. And remember, the retinacula at the end of the day is nothing else than a reinforcement of our crural fascia. So you can see right here our retinacula. And in this imaging you see crural fascia, superior extensor retinaculum of the ankle, inferior extensor retinaculum of the ankle. You don't see any border because it's just a reinforcement. Okay? And the aim is not just to keep the tendon in that place, but the aim is to perceive the motion of the ankle and give you proprioception. You will see people with functional ankle instability, they have problem in the retinacula. Okay, we published 3-4 articles about that. So functional ankle instability is not a chronic, unresolvable problem. You can fix. Okay, we prove with 3 publications that you can fix functional ankle instability. You can bring back your athletes to the field and play as before. Okay, it's not like a reversible problem. You have just to understand that where is the problem. The retinacula is the key element for functional ankle stability. So you see right here, retinacula and fascia above. And here you see superficial fascia, saphenous major, crural fascia, retinacula. This thicker white structure right here, this is the retinacula. I keep moving the toes of the patient up and down, so this is extensor longus that move, but this reinforcement right here, this is the retinacula. So retinacula is in perfect alignment with the crural fascia. Below the superficial fascia, where is included the saphenous major. What happened with trauma? and then we have to really go. With trauma, you can have a disarrangement of the connective tissue, and immobilization do the same. So if you basically immobilize an ankle for motor accident, you destroy the knee. You put 2 screws in the calcaneus, 2 screws in the trochanter, you put a piece of iron, and you try to reconstruct the knee, so the patient stay mobilized in this position for 3-6 months. If you save, or if you are not able to save the leg, the ankle will be a disaster. Because when you take off the screw, the 2 screws, you will see that all this area is, even if there was no trauma in the ankle, you see all this white, this is the retinacula, and that's fine, but all this white right here is nothing else that fibrosis. So this is normal retinacula. All this black right here is all fibrosis, okay? So fibrotic tissue means scar tissue. So it's a tremendous event. It will take a month to occur, but even the fascia can get to fibrosis in long term, okay? This is dramatic event, difficult to reach. If you reach this situation, it will be hard to get back. Functionally will go back, but anatomically will never go back, okay? This is like a normal situation with the skin, superficial fascia, reticular cutis, deep fascia, muscle. This is the other pathological patient. Muscle, this is a kind of deep fascia. This is the skin, superficial fascia maybe, but the pink is all connective tissue, so you have connective tissue all over, okay? This tells you how severe it can be, this situation. So remember, you can have a fibrosis, very problematic, extreme situation, or densification, increase of the loose connective tissue. Densification is a daily experience. Overnight it can happen. Small trauma will happen. But as fast as it comes, as fast as you can fix. Fibrosis takes months. It will take a month to recover, if you will be able, okay? Because not even necessary that you will be able to go back as before. But fibrosis, you need immobilization, infection, major surgery. You need that to get to such far, okay? Okay, so to conclude, what is missing is the epimysial fascia. We talk about aponeurotic. Epimysial fascia is the fascia of the trunk, or the fascia that surrounds each single muscle. So this is the pectoral major. We have lift up the pectoral major. You see like a one layer, another layer. It's like a sandwich. 2 layers with muscle inside. 2 layers, the muscle inside, and septa of perimargin that go through. So that means that the fascia of the trunk is inseparable for the underlying muscle. And whenever you palpate or treat the trunk, you can never say, I'm treating the fascia, I treat the muscle, because you are treating both. At the opposite, in the limbs, I say, I'm treating the retinacula, nothing else. You can do that, because if you palpate right here, you're just treating between 2 tendons and retinacula. That's it. You don't treat the muscle, okay? In the trunk, you cannot say that. It's inseparable. Inseparable, but in the trunk, you can have like a sensation, like you're working a structure that is more elastic, because the fascia have to follow the contraction of the muscle. So it's more elastic. But at the same time, you can have like a kind of tight bundle, because if the deep fascia become rigid, above, below the muscle, the red is muscle, the blue is connective tissue. So you can generate like a container. This container is perceived like a tight bundle. So a lot of times the trigger point could be just like the containers, like a epimysial fascia, perimysium. So this stuff become rigid and you feel a tight bundle during the palpation, because the morphology right here is different from this area. These are fusiform. These are like a bundle of muscle. Like in the deltoid, you see the perimysium structure. The trapezius is the same. You see the perimysium structure. Okay, so the anatomy right here is different. Also, the perception you will feel different. On top of that, you will see that the muscle, yes, surround the trapezius, then come together, the fascia. Then split, surround the deltoid, then come together. Then split, surround the pectoral minor, and come together. So the epimysial fascia right here is able to spread the tension much far away, as well to merge with the aponeurotic fascia. So one of the most beautiful part of this morning will be to see the continue how pectoral major merge in the brachial fascia. And as well, how you have a crossing. So how you can spray like a singlet across the middle line. Because pectoral major, epimysial fascia go in the aponeurotic fascia contralateral, rectoabdominal sheath. You see the difference? Epimysial fascia, aponeurotic fascia. Aponeurotic is multiple layer. Epimysial is just one layer. Or you see at the end, in the pubic area, the spermal canal, the inguinal canal, you see collagen fiber that cross the middle line. They cross the middle line. So you can have a kind of pubalgia spread on the other side. Neurologically, it's difficult to explain. Anatomically, it's very simple. Low transmission to the fascia. All right, so we have done, just take home message, we will see later on. In the limbs, aponeurotic fascia, thicker, up to 1.8 millimeter. Partially separable, few elastin fiber, but it's a multiple layer. So it's not adaptable, but it's perfect for transmit force. So the aponeurotic fascia is like a flat tendon, basically. Epimysial fascia, thinner, is strongly adherent to the muscle. So you cannot separate the function of the fascia from the muscle. The two work together. And so when it's time to assess to treat, you will treat as one unit, muscle and fascia in the trunk. And you will not see like the rough surface like in the retina. You feel like really click, click, click. You will not feel that. You will feel like a more tight bundle because it's like a container different. So different sensation, rough surface, tight bundle. Okay? All right, this was a pretty, deep jump in the fascia anatomy. This is a summary of 20 years of research, so I'm sure that it will be hard to collect all the information once, but I mean, if you really have 50% of the information, you are quite genius, because we take 20 years to learn all of that. So if there's any question, I'm happy to take it. Yeah.
I had a question. Therapeutically, in terms of the different fascial compartments, is there a difference between eccentric stretching and concentric stretching?
Yeah, good question. I will not say so much about the eccentric concentric. I will say ballistic and static. Ballistic stretching and static stretching.
Okay.
We are working on that. My sister is writing books about that. So our first basic information we can say, like if you have an aponeurotic fascia, like fascia in the inferior limbs, is just a little percentage of elastin fiber, almost zero. Static stretching, it works a lot because it's so rigid, you just pull once and then you will stress the tissue a lot. Trunk and also limbs, but upper limbs have like 77%, this is like a 20%. So in the trunk, a little bit in the limbs, there is a little bit elastin fiber, so it's adaptable. So if you do a static stretching, after a few seconds, the fascia adapts and you don't stress the tissue anymore. So right here would be more important to do like a ballistic stretching, okay, or dynamic stretching, because you have to stretch and load and load, load and load, in order to affect the tissue properly.
So in the lower trunk?
Lower trunk, thoracolumbar fascia.
Hamstrings, glutes.
Yeah, so right here is aponeurotic. So where you have aponeurotic fascia, static stretching can work very well. When you have an epimysial fascia, ballistic and dynamic stretching will be more helpful. Technically, but we are still working and there is more variable that has to be taken into consideration. Anything else?
They say fascia is responsible for 30% of muscle force contraction. Because the gluteus max is 80% connected, would you say that's responsible for more than the 30%?
Well, of course, but in the trunk it's 100%. So imagine, do you really believe that the pectoral major that have such large origin can fit in like a quarter of inch for a half inch right here? How all this muscle fiber can fit in this small space right here? It's impossible. It's physically impossible. The majority of the fiber of the pectoral major merge in the brachial fascia. We will see right after. So pectoral major, this is amazing for you because imagine if this is the insertion, you will do this every time. Rotation, elevation, and adduction. Okay, with a little bit variation, but this is what you can do, not much. If you have this large expansion in the brachial fascia, you have a large origin, a large insertion, a lot of motor unit, so you can do this, you can do that, you can do this, okay? The same with the glutes. If you have just an insertion right here, you will do this. Instead, in reality, you have such a large insertion, large origin, lot of motor units, and can do all this kind of movement, okay? It is have a double advantage because it means that I don't have, because you say, look, if I have this insertion, okay, I can activate the infraspinatus and so I can go straight. But if you activate the infraspinatus, it means that you increase the stress of the joint because someone pull in the front, someone pull in the back, and then yes, you go straight. But imagine how much mechanical stress you apply with the joint. In this way, you just smoothly do the movement. So this is why if you have a problem in the fascial system, in the long term, 10 years, 20 years, you start to have a problem in the joint. Because you overstress the joint. Because in order to do the motion, you have to co-activate the muscle that they should not be activated. Okay? On top of pain that you apply, on top of lack of proprioception as well. Drop in the coordination. So, yes, this I'm talking about deltoid. You will see we will do. I will break the insertion with my finger of the deltoid. I will hold I sacrifice the origin. I hold my deltoid. And you will see that I can do whatever movement I can to the arm without insertion in the humerus. Deltoid is the bride of the gluteus max. 80% go in the brachial fascia. It is amazing for you. Why? So it means that this one works for pulling up here. Huge leverage, better way to move. Imagine it's not an advantage for you to have muscle merger right here in the condylus because this is not a core part of your body, like in the knee. So you bypass the elbow. And you will see a lot of anatomical variation. Brachioradialis merged with the deltoid sometimes. So you bypass the joint, and what carry the weight is this muscle, not this one. Okay? If the fascial system works well. Otherwise, you start to have epicondylitis because discharge too much tension right here. You don't bypass. If the fascia doesn't transmit the force load properly. The same from the knee. Glutes transmit through the fascia lata in linea aspera tension down there. So the glutes have much more power as long as wide is the leverage, are stronger is the muscle. Okay. Biceps the same. With the bicep nervosis, you have a slightly wider arm, so you have a better leverage. Okay. So the fascia is really amazing if you think about how you can strengthen your power and improve the coordination. Sounds good?
Two questions. The massage guns are pretty popular. What are your thoughts on massage guns for treatment? And also a massage gun versus a tool versus fingers. What's your...
Alright, so as I say, you can use whatever tool you want. I mean, it's more important where you apply it and what you apply, okay? In the combination point, because at the end of the day, you have to restore the biomechanics. It's not enough to treat the pain. You have to restore biomechanics. If you want to give a long-lasting result, you have to restore the biomechanics. Okay. So my patients sometimes say, look, I'm good, that's it. No, lie down, I have to do one more. Because even if they are pain-free, I want to restore the biomechanics. Sometimes you have to work an antagonist that he doesn't care because he's like, I don't have anything more, pain is gone. But you have to restore the biomechanics. This is the most important. Then technically you have to make sure the tissue glides properly, okay? So the hand works very well because it's cheap and because you have a constant feedback, okay? When the tissue is rough, when the tissue starts to glide properly, okay? You can do it with your tool, no problem at all. If you are comfortable, let's go with that. But don't bruise the skin because the bleeding stimulates fibrosis, so it's not what I'm looking for. Gum, it can use to the gum, but the gum is more vertical. I would like more oblique. Maybe you have to work a little bit more in oblique direction because you want to heat up and restore the gliding more than stimulate the mechanical stress vertical. Okay, so feel free to use every tool. The combination of the point will make the difference. And of course, I mean the localization, the combination of the point. So that is the way to go. Anything else?
What did you say again about plastic surgeon? The one that they pull the fascia here?
I mean, plastic surgery, when you do lifting, okay, they understood, but in the past they didn't really know exactly what they were pulling, okay? So then I realized they are pulling the superficial fascia. But the superficial fascia include the mimic muscle, the muscle for expression. So pulling the superficial fascia right here, it means that you have a line of force, so this muscle will not contract as before. So you can change the expression of the face. So if you hook, instead of hook right here, you hook below, this muscle now can contract. So that publication explained that you have to know where you hook and you pull. Because whenever you make a hook and pull, you will generate a line of force. It will affect the muscle in that line of force. So you have to know exactly at which level you want to hook, okay, to preserve that. But we publish a lot of articles with the plastic surgeon because for face is important, for flat transposition is important. So they start to know pretty well deep fascia and also superficial fascia.
Do you mind giving like an example how you treat a bodybuilder versus a 75-year-old?
How I treat different? I mean, at the end of the day, there is not a big difference. I will tell you, there is a difference if you have like a 30 million picture, okay, rather than a huge, like a normal, sad type pain, versus one that have polio, for instance, okay. So polio or neurological problem in professional, high level picture, you have to, they have like a very delicate equilibrium, okay? So you cannot just clean up all the rigidity or the densification and just, close the eyes and make sure that you are sure they get better. Because professional picture, they don't have full extension of the elbow. But for the reason, they don't want to have full extension because they have much more better throw, okay? So if they come with shoulder problem, you have to be a little bit more delicate in what you want to, you have to negotiate, okay? Neurological patient that they have is lumping, some densification, you maybe don't want to leave because they want to, make a fulcrum over there to move forward, okay? But general population, if anatomy is preserved, you just treat, I always say, even professional athletes, precision evaluation will be the future, okay? Because now professional athletes, I work a lot with the baseball team, it doesn't make any sense to treat in acute situation during the season before the playoff. Because they are under stress, you just treat, I don't want to say random, but without a clear path in your mind. If you do a precision evaluation, with this assessment, with this anatomy in your mind, you know what's wrong, even the patient is perfect. And you can treat, you can do prevention. We published an article about soccer player, and we saw that the season went super smooth in comparison to the other one. I'm sure you can translate in baseball, in all the sport that have not direct trauma, direct contact. So tennis, baseball, golf, okay, that would be amazing. Apply this material. In fact, next year, already before COVID, we were already planning, but now we start with COVID. We have a couple team that we are now organized pre-season evaluation. So we apply this method before the season. For a couple days, the player can feel that it's different, but then you will see that they have more strength, more power, more coordination, okay? Something that you cannot do right before the final game, because the day after, you say, look, I feel my arm different in a better way. But, in a preseason, you can do that. Before the most important game, you cannot, okay? So, is the future, they are ready. They know that it is, because like prevention is the way to do for financial reason, because if they have a player, 30 million player is off, is a major loss. So they understood that since a few years. They have a lot of, invest a lot of money in gait analysis. They have a bunch of data, but they don't know how to do with that data. Because they don't know this anatomy, so look, how I can change that pattern if I have just a muscle insertion origin. Okay? It doesn't, that data doesn't fit with the basic anatomy that someone know. With the fascia anatomy, you know that there is so many vectors that you can really affect and give like some degree of difference in the way of throwing and so on. All right, pretty good. Ready to move on? All right, let's move there. Okay, so how we want to do?